morning, and thank you for joining us for the third session of using the ASAM criteria as a treatment matching tool for adolescents. Again, I am Liz Fellman with the Virginia Tech Richmond Center, and we are delighted to be providing the virtual conference management and technical support today. Thanks again for joining us today. And now I'd like to turn it over to Dr. Fishman.
Great. Well, good morning, everyone, and thanks for returning for session 3 in our continued series here, talking about approaches to substance disorders in youth. Today, we're going to take a deeper dive into treatment. You remember that last time we started talking about brief intervention and motivational approaches, where the key pivot point was trying to move people across with progress through the stages of change from pre-contemplation into maybe just ordinary pre-contemplation and then to contemplation. But the idea being, why would any youth want to connect the dots about their current difficulties and substance use? Why would they be motivated to want to cut down or quit? So today we'll go further into looking at some of the details of treatment, whether that's specialty treatment, if we move to the level of severity where you've made a referral and we're looking under the hood and what it is that specialists do, or if it's composed of treatment that you as generalists in non-specialty, non-SUD settings might want to bring bits and pieces of into your practice to know about them and to be able to shop in that tool chest. And we'll talk about the expert panel. We've talked mostly about motivational approaches last time, and we'll jump into the detailed cognitive behavioral treatment techniques, show you a couple of examples, and take a deeper dive into one in particular, the relapse chain analysis as an example. We'll talk about treatment for co-occurring psychiatric disorders, which, as I'm sure you know, are so common and so important. We'll talk about the importance of involving families and some ideas about how to do that. And we'll talk about the use of medications for opioid use disorder, that is medication-assisted treatment, or MOUD, medications for OUD. And we'll illustrate throughout with some case examples and discussions and try to take questions both before the break and at the end. Remember, as we've seen a couple of times, the expert paradigm, we're trying to match particular kinds of interventions and intervention settings to severity. We were talking about screening, universal screening last time, and how to approach those with experimental use, but not yet developed a disorder, how to do brief motivational intervention for those that are just beginning or have mild to moderate SUD. And today, we'll be talking about those in the kind of tween category here, perhaps those that are mild to moderate that need more and that you'll approach in your setting, or those that you'll refer for moderate to severe or non-responding levels of severity, and look at what specialists might do. So for our first topic, let's talk about CBT, or cognitive behavioral treatment. And here is a typical kind of table of contents, say, from any of a number of youth SUD CBT manuals. And there are many of them. And in your resource list, we have some examples that you can look at, but there are lots of commonalities, and not just commonalities, one CBT SUD manual to another, but CBT approaches. Those of you who do a lot of behavioral health work may have seen CBT for depression, CBT for eating disorders, CBT for anxiety, CBT for eating disorders. And there are elements that are common, and list, you'll see elements that are more specific to substance use. But those that are common include things about emotion regulation, target the developmental vulnerabilities that we talked about in session 1, that is awareness, anger management, depression, important for our co-occurring discussion, problem solving. But then you see things that are specific to skills in the SUD arena, refusal skills, the relapse chain analysis, which is one that I'm going to show you in some more detail, relapse prevention, planning for relapse, et cetera. And so each of these might be associated with one or a series of exercises. CBT, remember, emphasizes the development of skills. So you're going to have to be working with someone who might have the motivation to want to change behavior, to want to develop skills, to be open to this kind of work. But once you're there, that's the idea. And the idea is the worksheets that might be involved, the give and take, working with it. It's not just education and passively received information, but it's role playing and teaching and trying to, in an engaged and active way, get rehearsal of particular skills that a young person can apply in the journey towards recovery. One tool that we use a lot in the CBT world is the Readiness Ruler. And that of the notion that motivation is a waxing, waning, ever-changing thing, and that we want to be explicit in understanding and acknowledging in a credible way to the young person we're working with that we know that they're not necessarily in full-on action mode. They haven't necessarily saluted the flag of abstinence and recovery. And so we want to be explicit about how motivated are you? And this can occur for any particular question. How important on a scale of 1 to 10 is it for you right now to change your behavior on using substances, to change your academic performance, to change your interaction with your parents, whatever the particular target is? How motivated are you to do it? And that's important because they might say not at all. They might say very important. More often it'll be somewhere in the middle. And then the second part of this, how confident are you that you could make this change? And those might be different things. I want to make the change, but I don't know how. I need the skills. And if that's the case, then that's the opening for you to say, well, let's work on those skills because you want to do it, but you don't know how. And let's talk. And then exploring explicitly the motivation. You're only a 2. What would it take for you to go from a 2 to a 4 to a 6? And understanding in the pageant of the person's own life, how motivation might change. You're only motivated a little now. What would it take for you to get more motivated? Would that be higher recognition of trouble? Would that be that you're using more in a sense so that you are in more trouble? Would it be that other external forces have converged to push you and the like? But it's a nice way of constantly getting feedback about motivation. Particular CBT exercise, urge surfing, thinking about talking with a young person about their craving, about their hunger or desire for substances, for getting high. And if you can get them to acknowledge that subjective feeling, that's already a big breakthrough. And then how can you deal with that? And one of the tricks here, one of the psychological tricks is, rather than fighting it up the middle, you can't stop the waves, but you can learn to surf. Number one is learn the skill of looking introspectively for the subjective experience of, do you have that urge? Do you have that craving? Describe the details. Just by familiarizing yourself and being able to talk about it, you gain some mastery. And try for some detachment. This will pass. It isn't permanent. You are not your feelings. That's a very important point in emotion regulation exercise skills of all kinds. That is, these are only feelings, and they are not facts, and you can observe them as an observing person the same way that you might say, oh, my knee hurts. What am I going to do to try to deal with the pain in my knee? But I don't identify that I am my knee. It's not quite as easy when we're talking about a psychological experience. And it's not an emergency. We can ride it out. How long will it take? Will it take 5 minutes? Will it take 10 minutes? Will it take an hour? But if you just wait it out, it'll pass, and then you gradually learn to be master of it. Let's spend a few minutes now in some more depth on a particular CBT exercise, one of my favorites, called the relapse chain analysis. We'll talk about this young man. Tony is our case example. And he's a guy who is maybe in your office, and maybe you've been working with him and making progress because you've decided, beyond just a one session prevention, that you have the bandwidth to be able to do this kind of work in a general setting and see him repeatedly and continue working with him. Or maybe this is what's happening in a referral to a subspecialty provider, and then we're taking a look under the hood at what those folks are doing. And so he's 15, he's got cannabis use disorder, he's gone from pre-contemplation to contemplation, and even in dealing with you what the pros and cons are. You've been doing DBT work with, he has the external. Anyway, he's doing better. Fits and starts, 3 steps forward and 2 steps back. But most recently, he hasn't used for a week until this past weekend. He comes in and he tells you that he did use with a friend over the weekend. And of course, the good news is he's being honest with you and not covering up, and he's not pretending that this didn't happen, and he wants to explore it with you. And so let's talk about this technique, the relapse chain analysis. And the idea is that we want to explore with a patient, how did you get here? So you used this weekend, you had a lapse, how did you get there? And it's a puzzle. Why did you use? And that's a difficult question for most people, and especially for most adolescents. Why'd you use? I don't know. Well, never mind why. Let's focus on the what's and the who's and the where's and the how's. Let's just get into the description and the details. What were the circumstances that led up to the episode of use? And with those details, maybe we'll be able to make sense of it. Well, what happened? I don't know. My friend passed me a blunt and I hit it. What am I supposed to do? This is a technique to rewind the video, rewind the tape. What happened before that? What happened before that? Not jump in with some big, deep explanation at first. Maybe we'll get there, but let's just break it down into tiny steps. And that seems trivial to us, but it's remarkably unintuitive to the patients, and certainly unintuitive to adolescents. I sometimes talk about this as a slow motion rewind, or rewind slow-mo. And so I'm going to walk you through a conversation that you might imagine having with Tony, and going upstream, asking him questions, getting into the details, trying to do the explication of what's the script that we're looking at in terms of what happened. And as you'll see later, we'll use it as an opportunity to say, where were the points that we could have hypothetically changed the trajectory? How can we rewrite the script? What would you have done different at different inflection points in a way that he can't do intuitively, but you can help guide him? So the conversation starts, what happened yesterday? Well, my friend Trey passed me a blunt and I hit it. And where were you? We were at his other friend's house with a bunch of guys. And what were you doing? We were just watching football, chilling. And had you planned to go over there and smoke? No way. They just brought it out. I didn't know that was going to happen. I wasn't even that into it. Well, so did you say no thanks if you weren't that into it? No way. I couldn't say no. It just smelled so good. Well, did you leave the room before they lit up? No way. I didn't know it was going to happen. It all happened so fast. And besides, they'd say I was a punk if I did that. Well, so did you tell them you're on probation and that you're getting tested? They don't care. Well, does your friend get high? No, not a lot. He never has any anyway. And he's also trying to stay out of trouble with his parents. Well, what about the other guys? Yeah, I guess they do smoke. Well, didn't you know they would have some at the house? No, I didn't exactly know. Well, do you know those guys? Not really so much. One of them, Sean, goes to our school. Does he smoke? I guess a little, but his older brother smokes all the time. Well, could you have predicted? Well, I guess. Did you plan to go to their place? Nope, just happened. You mean you were mysteriously teleported there? And that's just a humorous reference to the idea that young people often can't find the causal links. I don't know how I got there. And I'm joking by saying, what, it was a mysterious force of Star Trek? What are you talking about? No, we walked over from Trey's. Well, did you plan that? No plan, just happened. Well, what were you doing before that? Well, before that, we were at trades, playing video games, chilling. Again, wrote answers, but we're starting to see the director's cut. What are the links? Where did it happen? What happened before that? Well, and then what? So his other friend hits us up and said they were hanging. Did you and Trey talk about whether it was a good idea? No, he just said, come on, let's go over. They have a mega big screen. That'll be fun. Well, why didn't you tell him that wasn't a good idea? Well, there was nothing else to do. We were kind of bored. And also probably he didn't think it through, because that's not the planful thing that adolescents with immature executive functions typically do. You know that. Well, if you guys were bored, did you make some other plans before that? Well, my mom said she could take us for Subway. Well, why didn't you do that? She said we had to wait for her to get home from work. Well, why didn't you wait? She's always working. She never has any time for me. She never does what she says. She's always saying this stuff. Well, did you have a meantime plan? Well, we were talking about maybe playing ball. Well, why didn't you do that? Well, because the courts are too crowded on Saturday. Anyway, this is the process. And those of you who've done this work before will see this familiar. Those of you who haven't, you can see the method and you can keep going and keep going. But the idea is to then use it as an opportunity to find ways that it could have gone different and to teach skills about opportunities for redirection, or as I call it, rewriting the script. So could you identify a risky feeling that gets you started towards using? And you're hoping that Tony will identify that being bored with nothing to do, idle hands are the devil's plaything kind of metaphor. He'll be able to identify that. And if not, you're going to help him try to identify that. And so what we've done is started now, and I'm going to show you a graphic of connecting the dots in a metaphorical way, although the graphic is more literal, from the prompting event, which hopefully we've identified for Tony as being bored, to this sequence, right? And he will not have been able to do this, but you've, through the exercise, been able to go through this and identified that we got from being bored to smoking weed with a bunch of intermediate steps, each one of them having some potential for being a step that maybe it could have gone different up to a point. And then very important to help explicate that there might also be, though, a point of no return. Because one of the things that you'll see all too easily that young people will say, or patients of any age might say, is, no problem, I'll just say no. It's like when you speak to your adult patients with alcohol use disorder who are frequenting bars and you say, well, what are you going into bars for if you're trying to stop drinking? Well, because I like going to bars, it's fun, I'll just drink a Pepsi. Okay, but how long do you have to hang out at a barber before you end up getting a haircut, right? It just eventually happens. So you can't wait till you smell the weed. There's no way that you're going to be able to say no there. So you got to go upstream, right? And find each of these other points, these other dots, as perhaps ways of intervening. So the way of having that conversation is to go through it point by point and asking and examining what are the possible intervention points and what could you do differently? What would be an alternate take? Where could we rewrite the movie script? And one of the metaphors I like, you've all had this experience, well, at least back in the days when we were going to movie theaters. I haven't been to one in a while, but when you'd be in a movie theater and you're watching a horror movie and the protagonist is trying to avoid a guy, right? But and the guy with the chainsaw is in the basement, but somehow the protagonist doesn't know. And the whole audience is screaming, don't go down there, don't open the door. And you're thinking, haven't you ever seen a bleeping horror movie? Don't go in the basement when there's a guy with a chainsaw in the neighborhood. But they do it anyway. So what you're saying to the young person is, how do you be a better predictor of what door to open and what not? And let's identify where we can rewrite the script. And is it being bored? Is it that you could have made some alternate plans? Is it that you could work it out with mom, even though you're so frustrated and that she does have to work, but could you problem solve it with her? Could you have thought about an alternative to the crowded playground? Are there other playgrounds? Is there another friend that has a basketball backboard at his house? Could you guys have gotten out a football and thrown that around? When Trey's friend texts him, could you have thought through, I wonder who else is going to be there? And does Sean's older brother use a lot? Do you kind of know that in the back of your head? Is there going to be weed at that house? Should you have thought about that? And I like the phrase unintended consequences, because you want to think, no, of course you didn't intend to do that. I know when you were going over to the big screen to watch the game, you weren't thinking, oh, cool, I'm going to get high. But think about the likelihood of unintended consequences, and can you do that? So this is this kind of discussion of the pros and cons, identifying where the point of no return is, and thinking about Sean's brother as a focal point of a person, place, or thing that's a trigger. You know, you can say you didn't know he'd be there, or you can think through, well, don't walk into a cave if you don't want to meet a bear. Your responsibility is to try to think these things out in advance. You could play the tape that your PO is going to test you later in the week. How could you use self-talk as a skill to tip the decisional balance? That is, I like getting high. On the other hand, I don't want to be in trouble with my PO. Which is worse? What are the pros and cons? Maybe you can blame it on being in the program. Maybe you can blame it on that stupid PO or that stupid judge. But whatever it takes, can you use those kinds of techniques? By the way, you noticed that you were anxious when you started to be concerned that this was moving in that direction. Nobody likes being anxious, I get it, but can you learn to use anxiety as a warning sense? And this is another trick we sometimes use in emotion regulation and in these CBT exercises. Think about your internal states, for example, the emotion of anxiety, as a warning signal, as a tool. It's like a spidey sense. How can you use it when your spidey sense is tingling to try to do something different? It usually doesn't happen for no reason. So you were mad at your PO. Fine, you can blame her. But if you act in anger and say, bleep it, I might as well just do it, who's the one who actually gets in trouble? You, right? So can you think of other examples where acting impulsively or in anger has been good or bad for you? And have you tried it to say that you can modify your behavior based on that? And when they say, well, I'll just say no, yeah, maybe you can, but how likely is that? And that's very hard. So let's go to a polling question about this. So the following statements would be evidence of progress for the target skills for the chain analysis. What would you expect Tony to say as evidence that things were progressing and were moving in the right direction? Everybody would select one and vote on what they're thinking would be a helpful response indicative of progress. Obviously, he might say any of these things, but what's the one you're hoping for? And press submit after you've selected. I can't really see. Is the tech working, guys?
Oops, sorry, Dr. Fishman. Yeah, we're ending the poll now. We've got 66% participation.
Okay, great. So there isn't necessarily a right answer, but most of you selected the one that I would have selected, which is I should try to identify danger points and make alternative plans to avoid them. That wouldn't be exactly the words that you'd expect a 15-year-old to use, but it expresses the context of the skill you're trying to communicate. What you might hear, which some of you selected, but not too much, is what I consider to be kind of empty jargon, this answer, which I've heard a million times. I guess I'll change persons, places, and things by avoiding negativity. It works if you work it. I just need to keep coming back and not pick up. And those of you who know something about 12-step mutual help will recognize some of those phrases, from the rooms. And what we don't want is for a young person to just parrot back phrases that they may not understand and then not actually be able to implement the content. We certainly are not particularly interested in their acting just not to disappoint us. That's not likely to be very impactful.
Also, they started that sentence with "I guess,"
Right.
not a "I need to."
Okay, nice. All right. So, all right. So let's move on from that to the next topic, which is treatment for co-occurring psychiatric disorders. So it's no surprise to you guys that other behavioral health problems, psychological problems, psychiatric disorders are very common in young people with substance use disorders. In fact, their presence in this population is more the rule than the exception. Some of the most common ones you'll encounter are depression, anxiety, traumatic stress responses, attention deficit. Sometimes, right, you'll meet young people who've gone through the system and have had severe behavioral health problems, and they may have a list of diagnoses as long as my arm because 7 different evaluators have given them 7 different alphabet soup diagnoses. That's not so helpful. But the notion that there is lots of co-occurring psychological problems that occur in this population is obviously paramount. And both psychotherapy treatments and medication treatments are very effective in this population, despite the co-occurrence of substance use disorder. And what I'm going to talk about is that an integrated approach in which psychiatric disorders that co-occur with SUDs ought to be treated concurrently. If you can achieve it in a one-stop shop, that'd be great. If you can't achieve that level of integration, at least with coordination happening at the same time, rather than waiting to do one and then the other. And lastly, that we know that treatment for co-occurring disorders improves the outcome for both. If you treat a psychiatric co-occurring disorder, it improves the outcome for an SUD disorder. If you treat an SUD disorder, it improves the outcome for the psychiatric disorder. And these are the core elements, but let's talk a little bit about the details. One issue, of course, is figuring out whether the person actually has a so-called autonomous co-occurring psychiatric disorder. So this question of chicken or egg often comes up. And I will say that sometimes it can be helpful, but more often than not, I actually think it's not the most important question. So we can sometimes identify that somebody had a pre-existing behavioral health condition before or even long before the age of exposure to substances, and then substances came along and made it worse. Say a 7-year-old with ADHD, we know that increases the risk of subsequent substance use disorder, and then the person starts using and it complicates it. Or in other circumstances, we might see that a person was on a fairly average trajectory of high functioning without a previous co-occurring disorder, then got into trouble with using substances, developed a substance use disorder, and then had symptoms of a co-occurring psychiatric disorder because of the effects of use. But more often, it's a jumble of both, isn't it? When did they start having trouble? Oh, I don't know, early teen years, 12, 13, 14. Yeah. When did they start using? I don't know, early teen years, 12, 13, 14, right? And those things go together. And so more often the rule, rather than being able to determine which comes first in a clear chronological antecedent, is that they co-occur with mutual exacerbation in a cycle of each one making each other worse. And we try our best to treat them at the same time, not waiting for one to clear up before the other does. Now, there are some salient features of a psychiatric history that might help us with that decision when we think it's important. That is, should we wait for the substance use disorder to stabilize, for a decrease or abstinence or a period of abstinence before we jump into specialty treatments for co-occurring disorders, like formal psychotherapy or specialty medications for depression, et cetera, or not? And so some of the ways that we look at that are family history of psychiatric problems, symptoms prior to substance use, as I mentioned, prior symptoms that persist during episodes of abstinence or reduced substance use, if there were such periods, like, oh, that summer I was at my grandma's down in Carolina, I wasn't getting high. Were you still anxious? Were you still depressed? I was locked up in juvenile detention, wasn't using. Yeah. How did your ADHD do, et cetera? Previous evaluations, previous treatments, previous response to medications. Those may be instructive, although you may not be able to have lots of information, especially if a person arrives at your door with, as I said, a long list of various different diagnoses and a long list of, I've tried this medicine, that medicine, but you don't know whether they've actually had actual adequate trials. I tried this once, I tried that once. They will say subjectively, oh, I've taken everything, but that may not actually be accurate. And then, of course, the more severe, the more persistent a psychiatric presentation is, the more you're concerned about urgency, the more likely you are to recommend and to undertake jumping into specialty psychiatric treatment. The good news is that most of our psychiatric medicines are relatively safe, even in a population of actively using youth. So we don't have to worry so much that embarking on medication treatment, say for depression, is going to harm a person, even if they're continuing to use, and especially if that use is alcohol and cannabis. If it's opiates, if it's benzos, then we might have some concern about those interactions, but even those are not as scary for psychiatrists as you might think. Just to make the point about how interlinked these sets of disorders are, here is data about the initiation of alcohol or illicit drugs related to whether or not a young person has had major depressive episode, MDE, in the past year. And you can see that having had a major depressive episode in the past year compared to not, doubles the risk of initiation of alcohol and triples the risk of initiation of street drugs. Now, I can't tell you which came first here. Was it the depression first or the substances first? But again, that's not the point. The point is that they go together and are mutually exacerbating. And not only is their initiation linked, but the prognosis for treatment is linked. Here is the treatment trajectory of two groups presenting with high severity substance use for residential treatment. And we're looking at the course over time from baseline to 12-month follow-up of folks coming into residential treatment, adolescents coming into residential treatment. We're looking at the severity of their substance use by how many days they're using. What's the percentage of the days that are using days? Not surprisingly, to come into residential treatment, you're high severity, so these kids are using most every day. But we've divided the groups into those that have a Beck depression inventory, BDI score, below 11 and above 11, 11 here being a reasonable cutoff for mild to moderate clinical symptoms. And the good news is that after a short course, say a month of residential treatment, there is a substantial reduction out at 3 months follow-up of using days, and then the classic check mark shape of an outcome curve where there's attenuation of the treatment response. They're out in the community, they're back in their drug-using peer group and communities. They probably are not attending community care and ongoing continuing outpatient treatment the way we like. And so there's some backsliding, but still at a year, residential treatment's been effective, and there's substantially less use than there was at baseline, not to zero, right? So there's room for improvement, but still effective. But when you look at the difference, those that started with substantial depressive symptoms do worse at every time point. They don't get as better, and they relapse more. So increased rates of initiation, worse prognosis in terms of treatment. So it's an example among the other co-occurring disorders that we need to pay attention. And what do we know from the treatment research literature about treatment outcomes? This is work from Dr. Paula Riggs at the University of Colorado. She's a friend and hero, one of the pioneers in doing this kind of co-occurring work with adolescents. And it makes the point here, and I'll tell you a bit about the study in a second, that when we do concurrent integrated treatment is when we get our best results. So this study was a multi-site study. I was privileged to be one of the sites in our treatment center in Baltimore. And the notion is that you're treating adolescents with depression and co-occurring substance use with fluoxetine, generic name for Prozac, versus placebo while they are getting ongoing SUD counseling, CBT counseling. And the first thing she found out was that if you give antidepressants, in this case, the SSRI, fluoxetine or Prozac, to actively using adolescents with depression, most of these youngsters were using cannabis and alcohol, so they were a moderate severity group, it's safe. So there aren't problems with treating the depression with antidepressant medications. Also, they get better, and fluoxetine did better than placebo. So fluoxetine, which is a standard treatment for adolescent depression, is both safe and effective in adolescents with co-occurring substance use and depression, and works better than placebo to get them better. But one of the questions was, well, but what about their substance use? If you treat the so-called underlying depression with a medicine and psychotherapy, will the substance use get better? And as it turned out, lots of people did have their substance use get better, good news, but those in the Prozac group didn't get better more than those in the placebo group. So the medicine didn't itself magically dissolve away the substance use. But remember, these patients were also getting CBT that targeted, counseling that targeted both substance use. And remember, I showed you the CBT manual table of contents. There's also material on depression. So they're also receiving depression treatment, even if they got placebo. So another way of slicing and dicing the data, and that's what's shown in this graph, is instead of dividing the group into active medication versus placebo, what about dividing the groups into those that responded in their depression, those whose depression got better, that's the blue group, versus those that were depression non-responders, that's the red group. And as it turns out, here we're measuring days of drug use in the past 30. Those whose depression gets better, whether that's from the medicine or the psychotherapy or both, are the ones whose substance use improves. Those whose depression doesn't get better, their substance use also doesn't get better. So it reminds us and documents the point that to expect one of these conditions getting better without the other is to set yourself up for failure. And you need to address them simultaneously, hopefully in an integrated way, and you're looking for a matched or coordinated or linked response of both conditions. And as it turns out, that works in ADHD, in other work that that Dr. Riggs has done and has been demonstrated across a variety of conditions. So that to me is very good news. Now, psychiatric medicines, as those of you who've seen this work or have done this work, as you know, there are frustrations to psychiatric treatments, right? Compared to other medical subspecialties, for example, antibiotics, we have poor specificity. It's harder to know in advance who's going to respond to what, to know what the right choice of medicine is, right? I got 20 different SSRI antidepressants. Which one should I use? The answer is yes. That's maybe not as helpful, right? So there's a lot of trial and error. These medicines are slow acting. That's a very frustrating thing when a family and a patient comes to you in distress. My kid is suicidal. Oh, don't worry. I have a medicine that'll make you not suicidal in 6 weeks. That's very frustrating, but it's the pace at which these treatments work. We don't have good laboratory or imaging verification of diagnosis, treatment choice, or treatment response. There's not a blood test. There's not a scan. We often put patients in the position of having to try one thing, then another, then another. They understandably complain, hey, doc, I feel like a guinea pig. Don't treat me like this. I get that, but it's what we have. These treatments typically require long courses and intensive monitoring. That's the bad news, but the good news is they are mostly effective. And if you can persuade patients and their families to go the distance with you and to keep at it, we can usually be successful. And it is a good engagement technique if you can get some improvement in psychiatric distress symptoms that you can then work in an ongoing way to link that to substance goals, because they will see, or hopefully you can demonstrate to them in the pageant of their own lives, that their distress diminishes both as the treatment progresses and as they make sampling ventures into cutting down and abstinence, and the treatments will therefore work better. I just want to talk about a couple of particular examples of these disorders, which are the common ones, and talk about some pitfalls and adventures that you will commonly see in treating co-occurring disorders. The terminology we use for depression is sometimes problematic because we know that depression, especially in adolescents, has lots of different mood symptoms. In fact, most young people who have depression aren't necessarily subjectively sad, right? They're cranky, they're irritable, they're angry. Those are classic symptoms of adolescent depression. But the patients and their parents will sometimes say, well, I'm not depressed, because what they mean is the common little d definition of sad mood. And so when we use big D for the diagnosis of major depression, that's sometimes confusing. Another thing that comes up is that lots of adolescents, perhaps more yes than no, will have mood lability or mood swings. But all too often, people hear mood swings and they jump to the conclusion of bipolar disorder. So we've had a fad of the overdiagnosis of adolescent bipolar disorder, especially in co-occurring SUD populations. Not saying that it doesn't exist. There really are cases of adolescent bipolar disorder, and many of them high severity, but 10 times less frequent in the population than major depression, which is 10 times more common. So we want to remember that overreactivity, poor frustration tolerance, mood lability, and mood swings are in fact a common symptom and a hallmark of major depression in this population, especially if you throw in intermittent intoxication. The classic combo is CBT psychotherapy for depression and SUD with antidepressants. SSRI antidepressants are often first line, but there are dozens to choose from. Those of you in general medical practice will get familiar with some and then refer to subspecialists as things get more complicated. But for sure, treatment improves outcomes in both sets of disorders. Anxiety is worth mentioning because kids talk about anxiety, have anxiety lots, and sometimes it gets confusing and people talk about, I don't have depression, I have anxiety, as if those are very different things. They're not so different. Anxiety is a very typical feature of the disorder we call major depression. Again, maybe there's a problem with the terminology. Maybe we should shift to a term like mood-itis or mood regulation-osis rather than major depression because it's confusing to people. But plenty of people with depression get anxiety. But it's all too often that we hear, I've tried everything and nothing works except what? Xanax. And unfortunately, benzos get overused and they get trouble for many co-occurring adolescents that have both substance use and easily overuse and lose control over sedative hypnotics like benzodiazepines and Xanax. The typical and classic effective treatment, again, is an SSRI plus CBT, but it takes time and it's slow and it's hard to persuade somebody who's distressed immediately and knows that using either a prescribed benzo or a street benzo or any intoxicant like cannabis, that gives immediate relief, but it's not sustainable. And it's hard to persuade folks that our approaches, although slow, are better in the long run. And it's important to remember that in addition to medications, psychological techniques that emphasize the CBT skills of desensitization, learning self-soothing skills, and increasing the tool chest of tools for stress relief is an important thing. And most youth with co-occurring disorders miss that part of the maturational trajectory that the rest of us have about learning what buttons, what tools we have to use to relieve stress. So you got to explicitly recreate that growing up maturational phenomena. What are you going to try? Are you a music person? Are you an art person? Are you a sports person? Are you a run around the block and jump up and down with the thrash metal turned up loud person? But we've got to explore a tool chest for stress relief that's different than and better than intoxication. ADHD is an important one. It's common, but figuring out is difficult. Depression can cause problems with attention. Substance use, for example, cannabis, can cause problems with attention and concentration. Demoralization and stress over life circumstances and distraction can cause problems with concentration and attention. We do know that the treatment of ADHD with stimulant medications in children prior to the onset of SUD is an important factor in preventing the risk and vulnerability to substance use disorders. So some people ask, wait, should I give them a stimulant? Won't I just whet their appetite? They're at high risk already. Won't they learn to use reinforcing substances? And in fact, the answer to that has been proven no. Good treatment for ADHD can be a preventative. We also know that it can be a safe treatment for adolescents with ADD, even if they are actively using, same as I showed you for depression. On the other hand, the notion that everybody smoking cannabis or drinking alcohol or using other substances who has a problem with concentration or attention automatically has ADHD is false. And so it's important to be careful about that diagnosis. It's important to know that there are many, or at least some, good non-stimulant medication treatments for ADD that might be first line for actively using youngsters. I certainly use stimulants with co-occurring adolescents, but I stop more stimulants than I start. And it isn't just because of the risk of diversion. In fact, that's less my concern. More my concern is the underappreciated side effect profile of stimulants in co-occurring kids. They tend to worsen depression and anxiety. They tend to worsen irritability. And so that can get you into trouble. But if they are right, as long as you monitor them carefully, we always use long-acting preparations. If you use the short-acting ones, people are more likely to misuse them or crush them and sniff them. And so you just need to monitor supplies. When you're starting stimulants in someone with a co-occurring substance use, you use shorter durations, a week at a time to begin with. You check drug screens, etc. But it can also be quite effective. And I just want to illustrate some of these points before we take a break with this case. So let's say you see this 15-year-old young woman, and she's brought by her parents, who describe social withdrawal, some irritability, a shift in her peer group, and some academic decline from her prior high level of academic achievement. And they don't know anything about any substance use. She hasn't told them about any substance use. They're thinking, I wonder if she has depression or anxiety, or help me figure out what's wrong. And when you talk to her, she says she doesn't feel herself. She has some preoccupying worries. She acknowledges she's irritable. Her concentration is off. She's not sleeping well. And you're going down the path of concern about depression, as well you should. But she also volunteers, both because you ask her, but also because you do universal screening, that she has experimented with cannabis, and she's used beer at parties some. She hasn't been using recently. And then as you get to know her, it comes out, well, that, yeah, maybe it isn't just in the past, and maybe there is more recent use. And she has ongoing weekend cannabis, maybe drinking. And although she acknowledges the depression, and as you explore the possibility of referral to psychotherapy or starting her on an antidepressant medication, she's motivated to do that, but she says, the substances are no big deal. It's only marijuana, it's only beer, everybody's doing it. You know, the same kind of typical thing that you often hear. So this is, I think, an illustration of being able to use the presenting problem of motivation for help with psychological distress and depression as a wedge in to the problem of substance use. And this is a person who's motivated to want to get help with psychological distress, sees treatment of depression, and the parents as well see that as a legitimate goal, but is still, although in preparation to action phase about depression, is still in pre-contemplation phase about substance use, about cannabis, about drinking. So trying to connect the dots for this person and linking how substance use behaviors might be associated with the problem that she's concerned with, asking her to address those things using your motivational interviewing or brief intervention skills, and getting her to try to approach the substance use behavior change as a way of improving what she initially is seeking with depression improvement. Hopefully we're going to do better than this. This is the Gary Larson view of me talking to an adolescent with co-occurring substance use and say major depression, and writing in my notes, just plain nuts. We're going to do better than that. And before we take a break, I want to take a look at the chat to see if there's some questions or discussion, and then we'll take a break. All right, we got some tech problems with the poll and the video. Do we get the copy of the presentation? Yes, we do. Here's a question. For SSRI medication, if one works for family members like a parent, is it more likely to work for the teenager than trial and error? So that's a great question. And yes, that is one of the tricks we use to try to select an agent to start with. I wish I could say that that avoids trial and error. We often need trial and error anyway, but I agree with that. Although the evidence is not super strong, it's strong enough to use it as a guiding principle. And so as you say, if there is a first-degree relative, a parent, a brother, a sister, a grandparent who's responded to a particular medicine, that's a pretty good starting place. Another trick I use is to look to use the typical side effect profile in your favor. This is especially true and more often useful in adult patients that have significant co-occurring medical disorders. So for example, a medication that is constipating in somebody that has a problem with diarrhea, or a medication that causes diarrhea in somebody that has a problem with constipation. But that's just an example. Another example that might be more frequent in teenagers is if insomnia is a big problem, some of the antidepressants, say mirtazapine, brand name Remeron, might be a starting place because it's helpful for sleep, etc. So those are some of the tricks that we can use, but unfortunately, trial and error turns out to be more common than you'd like. And so it's important to say that at the outset so that you set expectations. I apologize for the state of the art in my field. I hope we get it right the first time, but I'm pretty sure if you let me go 3 rounds, we'll get it. I hope it doesn't take 3, but if it does, please don't give up on me. And no, that doesn't mean you're crazy. No, it doesn't mean I'm treating you like a guinea pig. I'm doing the best I can, and that's how it often turns out. Hang in there with me. Some registration questions, a lot of registration questions. What are we teaching kids when we give strong stimulants to treat ADHD as first line? Aren't we teaching them to take a substance to make things better? Doesn't that contribute to addiction? So that's a great question. The good news is that the evidence so far for the average patient doesn't support that either treatment with stimulants for ADHD prior to exposure to substances, as I mentioned, seems to reduce vulnerability and change the risk trajectory. It's not curative, but helps with later vulnerability. And for patients at the age of exposure who are using, they can be effective and don't seem on average to contribute to diversion or make addiction worse. And in fact, if they are helpful in improving the ADHD, they improve response to concurrent SUD treatment. Having said that, though, there certainly are a subgroup of young people who do get into trouble with diversion, who are overly reinforced by stimulants. And so we've got to watch for that. We've got to watch for dose escalation. We've got to watch for non-responsiveness. We've got to watch for, as I mentioned before, the side effect profile of worsening anxiety or depression. And you sometimes get into a conundrum there where the stimulants are reinforcing despite worsening of depression, either because of their reinforcing properties, because they are, as you may know, direct dopamine enhancers, which is itself quite reinforcing, or it might be just be reinforcing that the symptoms of concentration are improved. But remember, a treatment response to stimulants alone does not a diagnosis of ADHD make. Improved concentration and decreased distractibility and increased focus, at least in the near term, not necessarily in a sustained way, but with 1 or 2 or a handful of dose exposures to a stimulant is just a biological pharmacological property of stimulants. In the same way, if you think in a much milder way of caffeine, right? The fact that you improve your focus by drinking or ingesting caffeine doesn't mean that you have a legitimate diagnosis of low Starbucks disorder. It just means that that's a universal biological property of stimulants. So you got to be careful. You got to monitor. You got to watch out that once people get a taste for stimulants, if it does actually improve their concentration, it's hard for them to give it up. That's why I sometimes lead with non-stimulants, but I certainly do go to stimulants as needed. And monitoring closely is important. Next question. Have you heard of GeneSight, and do you have experience with clients trying to use this to determine which medications may be helpful based on genetics? it's a very interesting conversation, and we could talk about it a lot. I won't spend a lot of time on it. I don't know that particular company, but I do know that there are lots of companies that use some of the lab tests to try to direct one to a choice of antidepressants. I will say that it's a very exciting field for future development. I think we're going to learn a lot. I think the idea of this emerging field that we call pharmacogenomics, which means the interaction between genetic profile and response to medicines and choice of medicines, is one that is very rich and promising. But I hate to disappoint you. My opinion is that we're not there yet, and that the existing products that are commercially available are really not that helpful, although they are hyped a lot. And the sales folks will try to assure you that it's the best thing since sliced bread. I think not so much. And that's another conversation perhaps to talk about the details. But I don't think that the technology has arrived to a place where it's better than careful monitoring of standard clinical outcomes. Is EMDR proven effective to treat addiction? No, there is not evidence of that. It is interesting as an intervention. There's some exploration of it for PTSD, as you may know. In my view, that evidence is on the weak side, but does exist, but not so much addiction. I have a client who uses methamphetamine for his ADHD. I've seen lots of patients who say they use street stimulants and it helps their ADHD. I'm not so sure that the data supports it, but again, I can't speak to any particular case. I think in general, a patient like that is probably best advised turn towards professional treatment with prescription stimulants of known quantity and known constituents. After all, street methamphetamine, isn't made with good manufacturing process with FDA approval. You don't know what you're getting. And so there's, I think, better approaches, but again, I don't know this patient's. I think we're getting to the top of the hour. So let's take a 10-minute break, and we'll come back to more of these questions later on. And I'll see you at 11:14, and we'll talk about families and medications for OUD in the second half. All right, welcome back, everyone. Everybody had a chance to stretch a bit. Let's transition now to talking about families, a super important topic in the treatment of adolescent SUD. And we don't do as good a job, I think, broadly in the field of adolescent SUD or young adult SUD treatment with involving families as I think we ought to. And there are a variety of historical barriers, not least of which is that the youngsters don't always embrace the idea. It is developmentally normative for youth, especially young adults, but adolescents as well, to push back against their sense that families are overly restrictive, that they're expected to be dependent on families, that they, especially in nagging them about problem behaviors as being intrusive. I'm all grown up, I'm 18 in one day, you can't tell me what to do, it's none of my mom's, et cetera, et cetera. And all of that is developmental. We want young people to be struggling towards emerging autonomy. On the other hand, those that are not doing well with substance use and co-occurring disorders need help. So that's part of the difficulty in implementing. Another is that many, even subspecialty clinicians, they don't have the training or the comfort level or the competence. And it's hard enough working with young people, but then add their families to the room and the other agencies involved in the intersecting circles of their care. And it's a lot of players. Our field has long focused on internal transformation. And while that's important, I think we've overdone the sense that behavior change has to happen through internal motivation and insight, most young people learn is by practice and doing before they have internal motivation, and external leverage and persuasion is, I think, very important, but has been under-recognized. There is a preoccupying focus on what has been called enabling. Some of you will recognize that term, others may not so much, but the idea is that we sometimes message to parents, especially for those with parents of those with severe substance use disorders, that certain behaviors might be reinforcing, that they're not as good as we want them to be about setting limits, that they need to realign the reinforcers and leverage to try to move youngsters away from getting away with it. On the other hand, as important, even factual as some of those pieces of feedback and advice for parents might be, what do you think parents hear when they're given that message? You got to stop enabling. We may not mean it, but they hear it's your fault, that you've caused this, that you're to blame. And that's certainly a non-starter for a welcoming approach of involving families. I think that there's been over-rigid concern with confidentiality in the field. And don't get me wrong, I'm not knocking confidentiality. It's a cornerstone of the treatment we do, but we're sometimes over-rigid about it. And as you'll hear me say, working with families to get to yes about being able to communicate transparently for the benefit of a young, I think ought to be our target every time. And the idea that, oh, that's a HIPAA violation, oh, we can't talk to you, I think is overdone. Just a cartoon example, I've seen this many times. Families tell a story that, well, and this is more in subspecialty care than in general care, but they're paying for the care. The kid lives with them. They're dropping the kid off at the treatment. They're sitting in the parking lot waiting during group or a therapy session. They're in the waiting room and they want to talk to the counselor. How's my little Johnny doing? Or they call, can I speak to the counselor? How's my little Johnny doing? And they get told, we can neither affirm nor deny that a person of that name is receiving treatment at this facility. Please call between the, and I'm exaggerating a little, but the idea is we can do better than that. And then lastly, I think another area has been that SUD and other behavioral health conditions are stigmatized, and they're seen by many as shameful and secretive and in the shadows. And it's hard for us to have open conversations about them the way we would most other health problems in a health treatment context. So having said that, those are barriers. We need to overcome them. We need to universally, in my view, make family support, family involvement, family engagement a goal of approaching youth with substance use and substance use. Families so critical in their contribution to monitoring and supervision and communication skills, in which we encourage the young people to be able to do this kind of disclosure themselves and get support from their families, but teach their families how to be supportive rather than punitive. And I don't think that the emerging autonomy and self-efficacy of youth is incompatible with empowering families. In fact, I think they're quite compatible. We can have it both ways. They work together, but it does take some work. And by that, I mean, you've got to set the stage early. You've got to go over the ground rules. You've got to say that this is where we're headed, that this is standard in the treatment we do, that we want everybody to be straightforward in this and practice it and getting the consents up front and setting the ground rules. This is what we'll do. This is how we'll communicate. Mom, you've got to be comfortable that I won't tell you all the gory details. Youngster, you've got to be confident that I won't blab behind your back, but I will call the cavalry when I need it. And I want to help you practice doing the disclosure. And I want to coach you and maybe role play in advance how you can communicate in the room and broker it, that be helpful, that's fine. But the rule rather than the exception should be your parents or other caregiving adults in your life care for you. And even though they may not have always done it the best in the past, you say they've been nagging, you say they're punitive, you say they yell at you, you say they don't understand. We can do better than that. And let's work towards letting them support you in the way that we know they want to and can learn how to do better. And typically families have more leverage, more juice than they realize, and getting them some guidance on how to build their leverage skills is part of this. So what are we going to do? We're going to encourage them to have the conversations themselves. That's true in prevention, in early intervention. That's also true in ongoing treatment or specialty treatment for those with moderate to severe disorders. Talk to the kids. Hope it alone is not an adequate intervention. You got to ask, you got to talk, you got to normalize it, you got to keep coming back to it. You should expect, we're talking to parents now, you should expect to hear, I don't want to talk about it, that's none of your business. You're still going to keep coming back to it. And it's a balancing act in these conversations, parent to youngster, the balance between the clear setting of limits, meaning that the right amount of use for a young person is 0. You shouldn't be intoxicating substances. In our house, that's the rule. But also having realistic expectations that just because you say that, of course, doesn't mean they're going to do that. We're not naive or Pollyannish enough to expect that they will follow those instructions, but you can have it both ways. You can set a standard, and then when experimentation and use happens, as it often will, you don't cut their heads off. And teaching parents how to be able to do supportive debriefing that continues the conversation while maintaining the standard of behavioral expectation, but that is realistic. A lot of parents are surprised that adolescents just don't get it. This goes back to our session 1 about adolescent developmental vulnerabilities, training parents that you shouldn't expect insight. You shouldn't expect adult level maturation. You shouldn't expect subjective, introspective capacity and executive function, forward strategic decision making. No, they don't get it. That's why we guide by behavioral instruction and example and by helping them work out. And you got to be consistent, but you got to pick your battles. And all too often, one of the things that parents get into, especially with higher severity substance use or co-occurring disorders, is wavering between the nuclear option. If you do this, I'm going to kill you. I can't tolerate this. I'm throwing you out of the house. You're grounded for a year or forever. Versus don't ask, don't tell. I don't want to know about it because I feel impotent and I can't do anything about it. And instead, we want to guide them to take a middle ground, which is consistent, which is the long haul marathon approach that an explosive nuclear approach is unlikely to be effective. And it's so interesting. I can't tell you how many times I get into these conversations. Let's say I'm treating, and this is a severe example, but let's say I'm treating an adolescent with injection heroin use, and the family wants to make a federal case out of, can't you get him to clean his room? And I'm like, well, we can't have too many goals and you have to prioritize. And, sure, cleaning his room is important, but maybe let's have the conversation this week be about the heroin use and risk of overdose. That's an overdramatic example, but you get my point. Keep your eye on the prize and pick your battles and know your leverage. Work parents, and this is a heavy lift, and you may not have the time or bandwidth to do it in general practice, but it's one of the key things that we do in subspecialty SUD practice is coaching parents about how to do better at behavioral monitoring and supervision and negotiating in shaping behavior. Using rewards to shape behavior, you got to give to get. Why should I have to bribe him to be good? No, bribing is giving people rewards to do wrong things. You're reinforcing good behavior, pro-social behavior, and progress. Well, I'm not rich. I can't pay him for this and that and give him a new car. And I'm not saying that. I'm saying every family has goodies that go, what are the goodies in your family? And learn how to be judicious in their use. Is it use of the family car? Is it a special meal? Is it treats? Is it pocket change? Is it going to the movies? Is it time with the family? Whatever is the goodies in your household, now link them to behavioral goals. You get more flies with honey than with vinegar. Be reward focused and catalog, inventory, and direct the juice you have, keeping your eye on the prize, not getting discouraged by small setbacks, doing role induction and expectation that, of course, this is going to be 3 steps forward and 2 steps back. Don't despair with lapses and setbacks. Keep going. Now, that's easy for me to say. These are hard lessons for parents to learn, but you get enormous bang out of these kinds of parental interventions and coaching strategies to be able to shape behavior in a youngster. And until the parents are on board, it's very hard for us as professional behavior. If the parents' attitude is, it's no big deal, it's okay if they smoke cannabis and drink in the basement as long as they do it under our roof where it's safe and they're not driving, I don't care about it. It's going to be very hard for you to change. You're still going to try, you're still going to work individually with the adolescent, but very important to try to work to get the parents on board in understanding what juice they have to exert leverage and to be oriented towards the importance of changing behavior. So you got to educate them. I think it's important to be explicit about a collaborative treatment agreement between the youth, the family, and the program or the clinician. Sometimes you might do that in a formal way, get it written down and signed. We do that a lot, especially with higher severity opioid using youth. Work, as I said, on parental skill building. Talk about what the family's explicit role will be in supporting treatment. Things as concrete as transportation. How's the kid going to get back and forth to treatment? If there's medicines involved, antidepressants or MOUD, as we'll discuss in our next section, what do the family know about the medicine? How will they know about medication adherence? Who's monitoring the medication? What will happen if things go bad? How will we communicate progress? Who's allowed to know what? Is the family going to hear about every drug screen? Is the family going to hear about every attendance or non-attendance? Is the family going to know about this or that? Want me to tell your mom if you were Mrs. Jones, how would you like to manage it if things don't go well? And thinking about a backup plan. Well, I'm not going to need that because I'm committed to this. Things are going well, thank goodness. Well, just in case, humor me, and let's have a backup plan and a backup to the backup plan. How would you like to manage this in your household? How would you like your parents to support you if, God forbid, things are not going well? And let's get that negotiated and documented up front in this brief nanosecond of motive before things get hairy and before everybody's into lying and relapse mode, if God forbid that happens. Another thing that often comes up is the families have use, either as normative use, as an example, or problem use that could be contained. That's tricky, right? Because the families might find that intrusive. I didn't come here to talk about me. How dare you? You don't know me. We're here to talk about Johnny, not about me. And you might have suspicions or you might have clear evidence that there's substance use or substance use problems in the household. And how do you address that? Because it's going to, as I said before, going to be very hard to change individual behavior by a youngster if there are all these forces, including ongoing use in the household, that counter that. So one approach that I like to use is what I call the universal precautions approach. And it goes something like this, which is to say, listen, I don't know you well, and I'm not saying this applies to you, but lots of families may have social drinking or social cannabis use these days is increasing across the country. Not saying you have a problem. I'm not saying you even do, but if perchance there are substances in the house, we're trying so hard to work with little Johnny on changing his behavior. And kids do what you do more than they do what you say. They're mimics. And so we often recommend, at least at the beginning, and I know this is a hardship, and I know I'm asking a lot of you, but a substance-free household, and I'm not saying it's forever, might be a help, do sources of temptation and sources of modeling. And that's kind of an end-around way of not having to confront, not making it explicit that you think that there's a problem when looking for that, but just to make the point that every with a substance problem teenager probably ought to be a substance-free household. Can you try it? Can you go there with me, at least on a temporary basis? Here's a case that we might discuss for a minute that illustrates some of the points we've been talking about. So a 16-year-old female who's brought by her parents, and again, there's some concern about depression. And the kid says that she's had a stormy relationship with a male romantic sexual partner who is a substance user, and she's ambivalent about the sexual relationship and feels like he pressures her, but she does want to discuss contraception and a clear motivation of hers to seeking care. And you screen, and she tells you reluctantly that yes, she has been drinking with him and his friends, and on several occasions has tried some pills. Learn more over time. She's been going to parties and smoking cannabis, and there's been pills. Are they opioid benzos? We could discuss alternative scenarios based on what the substances are. But again, she's relatively pre-contemplative about that problem. It's not that much, it's no big deal. But I wanted to emphasize a couple of points here. One is similar to the point we made before about the young woman seeking care for depression. Here is a young woman who's open and seeking care for contraception and for discussion about the role that sexuality plays in this relationship, seeking guidance. And so working with the goal set by this young person is your end. And she's seeking contraception, which is something you could do if this is a general pediatric or family practice conversation, or in a setting of counseling, she wants to talk about the relationship with the boyfriend. Those are things that you want to meet her where she is over, and they become bridge points to connect the dots over the substance use and his role in the relationship in promoting substance use, what she thinks or does not think about how it might be affecting her overall function, her concerns about depression, etc. So that's similar to the case we discussed before. Use the presenting problem as a way of connecting the dots, building therapeutic alliance, and continuing in a motivationally enhancing way, try to engage over the substance use problem, even though it wasn't the problem explicitly seeking care for. But now I want to add what do you do about communicating these issues to the parents? So she's going to be concerned, as you might expect, about what her parents know what she wants her parents to know about all of these things, about sex, about confidential reproductive health services, and about the substances. And so negotiating with about whether or not the parents should know, whether or not she could find that helpful, whether or not she's prepared, perhaps with some preparation and role playing, perhaps with your being a broker, whether she's prepared to do some of this disclosure, whether she can see her parents as being supportive and helpful in addressing these problems, or whether she sees them only as being obstructive and problematic and naggy, but trying to get to yes, and trying to stage things in a way, and it's not an emergency necessarily, you've got time. It's not about unilaterally going behind her back and saying, I don't care what you say, I'm going to tell your parents with you. Only very rarely do I ever do in circumstances that I judge to be very imminent dangerousness, but that's not this case. So getting to yes, is it today, is it next week, is it next month? And thinking about how the parents could be supportive, being explicit with her about what she wants them to know, what they're allowed to know, what they're not allowed to know, coaching her about, well, I know you want that to be a secret, but don't you think they should know something more about that? And again, as I say, getting to yes. All right. Let's turn now to our last chapter for today, medications for opioid use disorder. Sometimes we call it MAT, medication-assisted treatment, MAR, medication-assisted recovery, or more commonly now, the terminology is going to MOUD, medications for opioid use disorder. So I won't show you the studies, we don't have time, but just a quick summary of the evidence. You guys may know that there are FDA-approved medications for opioid addiction, buprenorphine, extended-release naltrexone, methadone. We've got and decades of evidence for their safety and effectiveness in adults. They are the standard of care for first-line treatment of adult opioid addiction. But the question is, how are they relevant or not to the treatment of adolescent and young adult treatment? And of course, we're concerned about introducing medication treatment to developing bodies, minds, brains, and concerned about side effect profile in all pediatric applications of adult medicine. And so the first piece of good news is that the evidence is very clear that so far there is no signal for safety problems conferred by chronological age. So for sure, those medicines, like all medicines, even Tylenol, have side effects, right? And so that's something that needs to be wrestled with, including in young people with these medicines. But young people do not have more side effects. They are not dangerous. There is no signal of safety problems in young people over and above the standard side effect profile of adults. So that's good news. A summary of the effectiveness evidence is that we have increasing strong evidence of the effectiveness of buprenorphine. There hasn't been as much research in young people, adolescents and young adults as there has in adults, but so far the studies are all positive, although as I'll show you, the outcomes are not as good as they are for older adults. Extended release naltrexone is also quite promising. There's not as much evidence about buprenorphine, about extended release naltrexone as there is for buprenorphine, but what there is leads us to an emerging consensus, both of safety and effectiveness. So they are effective for youth. They are becoming, and should be, in my view, the standard of care and first-line treatment for adolescents and young adults with opioid addiction. There is no evidence so far that a fail-first strategy is appropriate. What do I mean by that? The idea that young people should have a chance to try treatment without medication first, and then if that doesn't work, medication treatment is second line. there's no evidence for that. They are effective as first line. And by the way, thinking about waiting for a possible failure of treatment in opioid addiction has high possible consequences, can include a catastrophic outcome, including an overdose and a fatal overdose. So we don't want to wait for a failure. They should be first line. Longer is better. That is congruent with the adult evidence. There is no evidence for a predetermined arbitrary time limitation. That does not mean that young people need to be on these medicines forever. And I get that a lot from young people. What do you mean I need to be on this forever? I didn't say that. But unfortunately, the evidence is that most people quit them prematurely. And so usually it's that people are non-adherent and drop out of treatment. And that also goes for young people before they've had the full benefit. But we don't really know what the right duration of time is. And just to give you a rule of thumb, I usually say to young people I'm treating, at least give me a year. But that's a hard sell, I will say. But unfortunately, it's probably not even enough. I want to show you a little bit of the. Here is a big Medicaid state claims data of about 5,000 youth that received a diagnosis of OUD. Already, that's a special population because somebody has noticed. And out of the 2.4 million claims, a lot of individuals whose were looked at to come up with these 5 with the diagnosis of OUD, that works out to a percentage of 0.2%, which we know is substantially below the epidemiological data for the rates of OUD in this age group. So we know that detection is already a problem. But all right, let's say we've gotten to detection. Somebody's noticing. It turns out that only 3/4 of these young people received any treatment whatsoever for OUD, even after an explicit diagnosis. And half of them received counseling alone, and 1/4 received any medication. And for those under 18, that is adolescents, it was only 5% received medication. So we're not doing a very good job disseminating medication treatment for OUD. But when we do, this graph shows us some of the advantage. Here we have a treatment advantage, comparing those in this cohort that received medication versus those that received behavioral health counseling only. And you see in this survival curve of retention and care that there's a substantial increase in retention over a year for those receiving medication. And the good news is we can have our cake and eat it too. It's not medication versus counseling. It's that patients are retained in counseling treatment plus medication treatment longer when they receive MOUD medication treatment than when they do not. So let's have a polling question on this. If you guys could help me out with the tech. Just asking those in the audience if they've had experience or they've thought about this in your practice, in your treatment program. What's your comfort level in providing buprenorphine treatment to adolescents with OUD in your program or practice or your agency? Do you refer? Do you do it yourself? We played it. Just a sense of seeing where people are.
People are actively answering it.
Yep.
I'm going to keep it up another minute.
Please. All right, well, I think this is very helpful to see the wide range of people's views. And as we expect, it varies you all. Some of you are doing treatment that doesn't include it. Some of you would want to send people to specialists, but not do it on site or in your own programs or practices. Others would want to learn about it. And a few of you are already doing it. So all of those, I think, are reasonable answers. There is no right answer, but it's, I think, useful to see. And since most of you are not already doing it, I think we'd be broadly thinking about this as a tool for referral to specialty treatment, right? That's the RT in ESPERT. And here's just a joke about that. You know, if only it were that easy, if only all we had to do is prescribe more buprenorphine and refer people to buprenorphine prescribers, we'd cure youth OUD. Yeah, not so fast. One of the things that we know is that medication alone is not sufficient. But another thing that we know is that even medication treatment, when done well, doesn't work as well in youth as it does in older adults. That shouldn't be so much of a surprise. For the same reasons that we think about developmental vulnerability as conferring increased risk, it also confers decreased responsiveness to treatment. This is some data from a secondary analysis of a big adult medication for OUD treatment study. And this divides the population. It turned out among these adults, there were about 100 out of 450 or so who were young adults, ages 18 to 25. They were treated with medicines, either buprenorphine or extended release naltrexone for 6 months. And this looks at the survival curve of non-relapse. And at the end of 6 months, half of the older adults had not relapsed. Glass half full, glass half empty, good result, obviously room for improvement, but a ringing endorsement, I think, of the treatment. But only 34% of the young adults, ages 18 to 25, had not relapsed. Again, glass half full, glass half empty. Thank goodness, 34% did well, much better than they would have done without medicines. Lots of room for improvement because the other 2/3 of that group had relapsed. And so it's not just as easy as prescribing more medicine, but it's thinking about developmental approaches to adopting and adapting this treatment to the target population. One thing I think that is important to stress is that even if it's not sufficient, these medication tools are necessary. So medications are the most effective single tool we have in our tool chest for OUD. They are better if combined with a holistic, full complement of multimodal treatment. But without these medicines, those other components will not do as well. Not all youth will take you up on the full host of other things you're going to offer: the counseling, the therapy, the 12-step meetings, the family therapy. Those are all. But even if youth won't take you up on them, these medications are potentially life-saving directly because they can prevent OD and death, which is the worst outcome, and so a decent starting place for improving outcomes. One of the things that I will say about a medication-first approach to the treatment of OUD, and it's not for everybody, but the reason I advocate it is that it's easier and more familiar for families to digest. If you think about specialty SUD care, it's a little mysterious. What is it you people do in group? You hold hands and talk about your feelings and say, especially, what's the shake? And I'm exaggerating, but most families understand about taking somebody to the doctor for a medicine when they're very ill. And so the idea of identifying this as a medical illness that can be treated in a medical setting is the sharp tip of the spear, perhaps, the wedge of entry into treatment from which other modalities, components of treatment can follow. You know, every mom has struggled with a cranky 4-year-old with an earache that doesn't want to take the pink medicine, right? So that's mom 101. I got a sick kid. They're not themselves. They don't know how to utilize medical care, but I'm going to take them to the doctor. Oh, I got this icky pink medicine. I got to get it in them. And thinking about mobilizing family resources around medication treatment with family responsibility for medication adherence and making that an entry point. And we've been doing some work in developing a behavioral wraparound treatment with that approach. We call it YOURS, Youth Opioid Recovery Support. And it has these elements: assertive, that is being a used car salesman, going out and working and chasing people rather than waiting for them to come in, involving families in the way I've talked about, delivering medications, especially injectable long-acting MOUD in home settings, and giving rewards for receipt of medication. Anyway, we're doing some research on that, developing it. Stay tuned. We'll see if it's the way to go. But even if you don't have the resources to do this big lift that I'm kind of doing through research grants, the idea of emphasizing family involvement and a medication forward approach is, I believe, very, very helpful. And here's an illustration of the power of this approach, kind of the poster child, a 21-year-old young man with a history of severe injection heroin addiction, had several detox admissions over a couple of years, gets extended release naltrexone a couple of times in rehab, but never follows prescribed outpatient care, never comes back for a second dose, hasn't really had the value of MOUD that I'm advertising. And this could have been extended release naltrexone, this could have been buprenorphine, you know, whatever. You're saying this is what you should be doing in an ongoing, enduring, continuing care way, but he doesn't do it. And so in this YOURS intervention, we hook up with grandma. He lives with grandma. She's the adult caregiver. We come out a month after discharge with the prescribed dose of the medicine, extended release naltrexone in this case, could have been extended morphine. And once again, he says, you know what? I don't want your stinking medicines. And whether he says that because he's relapsed or planned to relapse, or whether he thinks he's invincible and doesn't need the medicines, either way, he's going to go back to the same behavior, except grandma's involved now in a way she hasn't been involved. And she has more juice than we have. And she has the love and the caring and the relationship and the authority and the persuasion to be able to say, no, no is not an option. You're getting the medicine. And in this particular case, it's a done deal, and he does well. Not everybody does that well, but this is the sweet spot for our aspirations. Some other emerging care models include integration into primary care, where the primary care office is a spoke relying on the support, consultation, expertise, and backup of a subspecialty. Collaborative care consultation, where just like you've got an endocrinologist on speed dial for caring for your brittle diabetic patients, working with specialty care providers who can get on the phone and give you real-time consultation. These are models that you may have seen in primary care mental health. Going upstream for linkages to earlier presentations, overdoses in the emergency department, hospitalizations, say in psychiatric hospitals, or for medical consequences of OUD like soft tissue infections, criminal justice settings, school-based delivery of MOUD, and obviously longitudinal approaches, because as I keep saying, it's a marathon, not a sprint, and we're not expecting curative results from any of these medicines. And rather than talk about the case, why don't we take some questions in our last remaining minutes? Let me go to the chat. Here it is. What are your thoughts on multiple therapy and functional family therapy for treating co-occurring. That's a great question. Some of you may know that there are very high intensity family treatments. Those are two examples of a class of treatments called the structural family treatments. There are others like multidimensional family therapy and brief systemic family therapy and others, and they are very and highly effective, but they are hard to scale, hard to replicate, hard to do, require a lot of training with advanced therapists, careful fidelity to manual treatments. And so they're not for everybody, and they're hard to scale. So I'm all for them. If you guys have resources to carry them out, they are very good for co-occurring disorders. They have been tested in settings of co-occurring cannabis and alcohol use. They are now being explored for co-occurring opioid use disorders as well, but difficult. And so part of my approach, what I might add for lesser resource environments and for the non-specialist, is stealing some of the easier elements of family therapy that I've been talking about today, not these family therapy models that require high fidelity and intensive training with manuals, but some of the elements of getting families involved, working on communication, and bringing out some of the easier to intuit strengths of family involvement. Is MAT even legally available to prescribe under 18 years? Great question. So the labeling for buprenorphine is 16 and above. The labeling for extended release naltrexone is 18 and above. But as many of you will know, most of what we do in all fields of medical practice is off-label. And what that means is that once a medicine is approved by the FDA in a particular target population, if there is good evidence that it is safe and effective in other target populations, it is legal and approved and common and encouraged for thoughtful physicians to use medicines in a variety of other settings, perhaps for other disorders, for what there is evidence for other age groups, for what there is evidence for. Now, that is not to say do anything you want willy-nilly. It's with evidence, with thoughtfulness, in a defensible way, but it's what we do for most things. And the reason is that a drug company might spend a whole lot of money trying to get FDA approval for disorder X, and once it's out, it wouldn't be worth it for them to spend the money on all the studies and regulatory approval process to get approval to use it for Y, even though everybody knows it works for disorder Y. So that's a very common thing, and that's a long-winded way of saying that it is legal, and I encourage the use of MAT, MOUD for adolescents below the age of 18, again, with a thoughtful approach, with the proper developmental adaptation and supervision, but both extended release naltrexone, perfectly appropriate in younger teenagers. Methadone's a bit of a separate story because of the highly regulated environment in which it's prescribed only at specialty opioid treatment programs. And so, and the evidence for the use of methadone in younger populations, in my view, is less. Do you have knowledge of reputable treatment centers for youth in this area? I'm going to leave that to people that have more knowledge of local resources. I see that somebody said, yes, there are other agencies in our area, and I am also encouraging one at our facility. But it raises a very important point, which is know your local resource map. Get to know who's who, work with specialty providers to make these referrals, to identify who's expert, who can do what. We're going to talk more about that next time in session 4 as we talk about our T component and what the elements of specialty referral are. But unfortunately, I don't know. And if anybody has specific information about that, please let's disseminate it to the group, because it's important to know who can provide those services locally. I want to know how it turns out about the yours model. So thanks for the endorsement. Cool to hear. I don't remember if we included articles on that research in the resource packet. Remind me if we didn't, and I can get those to people if they want it. Again, I can't say that it's ready for prime time. We're in our early stages of development. And even if it does work out, I can't tell you how to pay for it in the real world. You know, right now I have research grants that support it. What would be its dissemination broadly? On the other, I'm encouraged and optimistic because those of you who work in mental health arenas may know that community outreach teams for persistent and severe mental illness, say schizophrenia, with assertive community treatment or ACT teams, is a very common modality of treatment across the country, has support in the public sector in many states, including, I'm sure, Virginia, I know in Maryland. And so it's not a huge leap to say, well, what about doing ACT for youth OUD? And what's the way that that could fit in to standard Medicaid reimbursement? Anyway, stay tuned on that. I know that I've experienced difficulty trying to parse out medical interactions, as well as having clear communication with families and collaboration with prescribing physicians. It's helpful to get more information regarding impact, interaction rate with co-occurring disorders, but it's frustrating to find time with a requirement of 30 clients per week, outpatient department of a community agency. Well, I can definitely feel your pain. You know, the American medical system that pushes general care settings and even specialty care to crank out volume in such a way, you know, it's hard to do this work in 7.5-minute office visits. I'm exaggerating a little, but not much. And so finding the resources, as you say, about in wraparound and other resources that can spend the time among the higher severity group to be able to devote the time that it takes to manage these tough cases, to work on family involvement, to work on co-occurring issues and the intricate issues of medication and psychotherapy, for sure. Here's a comment: available in Virginia and can be allowed for youth under 18 using EPSDT. My guess is, and that's great news, my guess is it probably requires major mental illness diagnosis like schizophrenia, bipolar disorder, et cetera now, but imagine a future in which OUD could be a qualifying diagnosis. So wouldn't that be cool? All right, so we are open, and I don't want to keep everybody. I hope this has been useful, helpful. Thank you for your attention, and we'll come back next time with part 4, in which we take a deeper dive into treatment matching using the ASAM criteria, talking about specialty treatment, care coordination, referrals. So looking forward to continuing the conversation, and see you next time. Thank you.
Thank you.